Well, good evening, everyone. Dr. Chris Sapienza here for another free webinar by Aspire Products. We're just waiting for our participants to join in this evening. We're very fortunate to have Dr. Michelle Troche with us, Associate Professor from Teachers College, Columbia University, also serving as the Program Director there of the Speech Pathology Program. Michelle and I go way back. It's been too many years. I keep always thinking of my former PhD students as my PhD students, and they have gone on to have very rich, mature, productive experiences academically, professionally, inside their own grant work, inside their own scholarship. Tonight, we're going to spend about 30 minutes listening to Dr. Troche talk about EMST, expiratory muscle strength training, and really the collective work that she's done around airway protection for a specific group of patients with Parkinson's disease. Michelle, it is so great to see you. It's been too long. I can't wait to hear your talk. I'll turn the microphone over to you. Thanks for being here tonight.
Thank you. So I am so thankful for this opportunity to spend time discussing this work, but also spend time with Dr. Sapienza. These are my disclosures, but like she mentioned, I should also disclose that I was so fortunate to be her PhD student and learned so much about expiratory muscle strength training from her, given that she was a true pioneer in that realm. And so I am thankful to share this virtual space with her tonight and with all of you. And so I hope you'll chat your questions as they come up. And, you know, my focus, like Dr. Sapienza mentioned, is really going to be on our work in Parkinson's disease and expiratory muscle strength training. And I come to you from New York City, beautiful New York City, and Columbia University. Here, I direct the laboratory for the study of upper airway dysfunction, where my research is aimed at improving health outcomes and quality of life associated with disorders of swallowing, cough, and speech production. And most of this work has been in neurodegenerative disease, particularly Parkinson's disease. And so it's going to be a relatively short talk, but hopefully jam-packed with information. And so I wanted to start with what we know about people with Parkinson's disease as it relates to airway protection. And so I think what we've learned over the last several years is that people with Parkinson's disease quite commonly have progressive and pervasive disorders of both cough and swallowing. And so if we consider cough and swallowing kind of on a continuum of airway protection, where swallowing is really focused on kind of preventing food or liquid from entering the airway, and cough is then, right, the form by which we eject that from the airway. And what we know is that they share a lot of things. One is that they all require kind of reconfiguration of the ventilatory breathing cycle. And so basically what that means, right, is that if you're going to effectively, efficiently cough or swallow, there are certain accommodations that your respiratory system has to make. Additionally, cough and swallowing share kind of both peripheral and central substrates. And this is a framework that I developed some years ago with Dr. Karen Hegland, who is also a PhD student of Dr. Sapienza's, where we kind of laid out the shared neural control of cough and swallowing in a very general framework. And then here I've overlaid the work that we've done over the years, showing that folks with Parkinson's disease have multifactorial deficits of airway protection, but that they do show potential for rehabilitation in many of these areas. And so some of those deficits include that they require more intense cough stimuli to trigger and sense a cough. They have reductions in their perception of cough stimuli. They have disordered voluntary control of cough and peripheral respiratory muscle weakness. And all of these can result in functional disorders of cough. But what we know is that they also tend to be exacerbated in folks that also have swallowing dysfunction. And so if we're thinking about this framework, right, one way that well, those of you that might be speech language pathologists, some of the ways that we can rehabilitate this or kind of break into the system would be kind of at the peripheral level, right? So somehow increasing muscle strength to help improve some of these functions. And so herein begins our discussion about expiratory muscle strength training. And so many of you probably know some about EMST, and I think that Aspire has several other kind of webinars that have good introductions to expiratory muscle strength training. But generally, with this type of approach, we're mechanically overloading the expiratory muscles using a device, which you can see here, which has a one-way spring-loaded valve, which only opens when a target expiratory pressure is reached. And this device that's here, the EMST 150, was developed by Dr. Sapienza, Paul Davenport, and Danny Martin. And I think that when it was first developed, the focus really was on improving specifically respiratory muscle strength, expiratory strength, which we do know is very important for cough effectiveness. But over the years, we've learned that EMST seems to have a place for rehabilitating airway protection beyond cough because of various mechanisms. And so in the early times when we were studying expiratory muscle strength training, it became evident that there were some other kind of muscles that were activated when you breathed through the device. So here you'll see some images, kind of video x-ray images. And on the bottom, so the top is just someone quietly breathing, and on the bottom is someone exhaling through the device. And so what you'll see is that some of the biomechanical things that happen during swallowing were happening when people breathe through the device. So the tongue base retracts, the soft palate elevates, there's some hyoid elevation as well. And so in Dr. Sapienza's lab, we became interested in kind of understanding this, and Dr. Hegland did some of this important work where she used EMG to compare expiratory muscle strength training. So here in this middle figure, this is from the first study in 2007, where she looked at just EMG for dry swallow, wet swallow, and then EMST at 75 and 25% maximum expiratory pressure. And what you can clearly see is that there's increased and prolonged activation of the submental muscles during breaths through the device. She then went on in a subsequent study to compare expiratory muscle strength training and effortful swallow and the Mendelssohn maneuver. And what she found is that, yes, the kind of EMG activation was comparable across these, but certainly EMST is not swallowing. And so the way in which the hyolaryngeal structures were moving were very different between EMST and swallowing. And again, this isn't surprising because expiratory muscle strength training isn't swallowing. There have also been some other more recent studies. So Kate Hutchison in 2017 did a study using high resolution manometry and found that while breathing through the device, there was an increase in VP closure, palatal EMG, and pharyngeal EMG. And then also found that intraluminal air pressure increased in conjunction with the EMST setting as the setting went up. And even more recent work by Pawlowski here in 2021 has identified that after 5 weeks of EMST, there's an increase in the cross-sectional area of the geniohyoid muscle, a suprahyoid muscle for swallowing. So certainly a rationale there for potentially using expiratory muscle strength training to improve not just cough, but also swallowing function. And so, Dr. Sapienza embarked on completing the first clinical trial of a swallowing rehabilitation approach in Parkinson's disease. And here we used expiratory muscle strength training. And at that time, I was a student in her lab and was able to participate in that work. And so the work was a prospective, blinded, randomized, sham-controlled clinical trial. Participants with Parkinson's disease were assigned to either receive active expiratory muscle strength training or some sort of sham, like a placebo device. Both the participants and the clinicians were blinded to the group that the participant was assigned to. We completed baseline assessments. They then did 4 weeks of training and then returned. And specifically for swallowing, we were looking at video fluoroscopy. We had several thin liquid boluses of 5 milliliters or 3 ounces. And we also looked at the swallow. And so the study included 60 participants with Parkinson's disease, and you can see that those folks were moderate disease severity, so usually about Hoehn-Yahr stage 2.5 or 3. They were pretty well matched in terms of age and disease severity. They completed expiratory muscle strength training. So each week we assessed the participants' maximum expiratory pressure. And then the EMST, or the sham device, though we didn't know that it wasn't actually being set at that level, was set to 75% of the participants' MEP. They completed 5 sets of 5 repetitions for 25 repetitions per day. And so they were meeting once weekly with the clinician, and then 4 days doing that training on their own. So for a total of 5 days per week. And again, that was over 4 weeks. In terms of the results for swallowing, what we found is that the participants that were in the experimental EMST group had a significant improvement in their penetration aspiration scores. And we found that age, sex, and disease severity did not influence those treatment effects. In terms of swallow timing, there was a significant decrease in duration of hyoid movement in the sham group. And hyoid displacements increased in the EMST group, and both groups showed improvements in their quality of life. Dr. Sapienza and Pitts also reported on the cough outcomes from this study. And what was found, again, after these 4 weeks of training, were reductions in the inspiratory phase, the duration of the inspiratory phase and compression phase. And so actually, in case you don't know about cough, let me give you the really quick and dirty tutorial. So here in green, you see what kind of a normal cough airflow would look like. And so that first dip, that's where someone's kind of taking a breath in. We can look at how long that is. That would be the duration of inspiration. Then that flat line, that's where, the vocal folds are coming together. We're developing subglottal pressure. Then there's a really rapid opening of the glottis, and then we get that real big peak. And so we can look at how long it takes to get from the end of compression to peak and how high that peak is. So what was found is that after 4 weeks of expiratory muscle strength training, there was a reduction in the length of that inspiratory phase and in the length of the compression phase. And there was a faster rise time. So people were getting from compression to that peak faster. And this translated to an improvement in cough volume acceleration, or a measure, kind of a proxy of cough effectiveness. So these findings were really exciting. We were excited to find that expiratory muscle strength training could, in fact, or had potential to improve swallowing and cough in people with Parkinson's disease. And since then, there have been some studies that have certainly corroborated this by other research groups. Alvaro Reyes in 2018 did a study specifically looking at cough peak flow, so that peak value that I was telling you about. And he did a study in 31 individuals with Parkinson's disease. He had a control group, a group that actually got inspiratory training, and then another that got expiratory training, and found that the magnitude of increase in maximum expiratory pressure and voluntary cough peak expiratory flow was greater in the expiratory muscle strength training group as compared to the control group. And that reflex cough peak flows had a moderate effect in the expiratory group as compared to the control group. So some consistency here that perhaps EMST does in fact improve cough peak flow or cough effectiveness in Parkinson's disease. And this was then another actually recent randomized clinical trial by Dr. Klaus and colleagues in Parkinson's disease identified that when comparing EMST and sham, that again, the EMST group had improvements in swallowing safety and efficiency. And here the instrumental swallowing evaluations were endoscopic evaluations of swallowing. There have been some other studies that have looked at kind of other aspects of expiratory muscle strength training and Parkinson's disease. One was kind of a single case report of a woman with Parkinson's disease. But I think what's really important here, and here we're just looking at maximum expiratory pressures, is that you see as people continue to train, even in a degenerative disease, here you see those maximum expiratory pressures going higher and higher and higher. And this is something that we haven't really studied in the research space, right? Which is if we were to continue training people past 4 weeks, past 5 weeks, past 8 weeks, could they continue to see functional gains? Or maybe there's some sort of threshold or ceiling. It's something that we don't know, but it's interesting to see that there's this continued response over time. Kind of on the opposite side of that, a subgroup of the participants who were in that first randomized clinical trial went on to detrain for 3 months. So they stopped doing expiratory muscle strength training for 3 months. And the findings aren't surprising, right? We all know what happens when you stop going to the gym. I don't need to tell you what happens. And you can expect that that's certainly going to be accelerated in folks with some sort of neurodegenerative disease. And so we found that the good news was that the maximum expiratory pressures did stay above their baseline. So before they had training, even after the 3-month detraining period. But what we found is that the swallowing improvements didn't really stick as well. And that's something to keep in mind in terms of the types of follow-up that we give to patients who receive expiratory muscle strength training. We probably have to be thinking about some sort of maintenance approach to maintain that strength or those functional gains. And so this work, looking at expiratory muscle strength training for airway protection, has been extended in a lot of different populations. So beyond Parkinson's disease, now we know of improvements in airway protection post-stroke and with ALS and in multiple sclerosis, sedentary elderly, even head and neck cancer. So certainly a developing literature to support the fact that for some, probably not all, patients, that expiratory muscle strength training has potential to improve airway protection. Now, in my lab, we became particularly interested in what the gains to airway protection would look like if we used a different approach. So like I mentioned before, folks with Parkinson's disease don't just have deficits in muscle strength or reductions in muscle strength. They really have a primary disorder of motor organization or coordination, right? And so we wondered, how about if we used an approach that was kind of more skill-based training for cough? And so some years ago, we embarked on a randomized clinical trial comparing expiratory muscle strength training to a novel skill training approach for cough that we called SMTAP, so sensory motor training for airway protection. And this work was funded by the Michael J. Fox Foundation, so I should thank them now for that important support. This was a prospective phase 2-site randomized controlled trial. The second site was the University of Florida. So this was work I did in collaboration with Dr. Karen Hegland. Participants were randomly assigned with allocation concealment to either receive EMST or SMTAP. And then they were further randomized to receive either immediate training or delayed training. So if they were in the delayed training group, they had a 5-week wait to start, and then we did the baseline evaluation. Once treatment commenced, all participants received 5 weeks of intensive training, which included weekly meetings with a trained clinician and then 4 days of home practice. And following the 5 weeks of treatment, they returned to the lab for a post-assessment. And so we've already described expiratory muscle strength training, so I won't describe that again, but just to say that, to highlight that in this study, as compared to the first randomized clinical trial, participants did 5 weeks of training versus just 4 weeks of training, but they were still training at 75% of their maximum expiratory pressure. So the other treatment that participants received, like I mentioned before, was sensory motor training for airway protection. Again, this was designed more to improve cough coordination. And so it includes several kind of key features. So we provide a salient context for the execution of the sensory motor behavior. And so in this case, it's subthreshold levels of capsaicin. We did this because we wanted them to kind of be able to sense like something was there, but that it wasn't a reflex cough that they couldn't suppress. And so we wanted to go beyond just trying to train the voluntary cough and kind of more towards the type of cough that you should have in response to airway invasion. It included a verbal cue to cough hard, a visual target, which was set at 25% above their baseline peak flow, and visual biofeedback throughout, providing this kind of real-time assessment of their cough. And then a real emphasis on the urge to cough. So their perception of that cough stimulus with hopes that it would kind of transfer to experiences of airway invasion. We try to match it to the dosage, if you will, of expiratory muscle strength training. And so they completed 25 repetitions of this training, just like EMST. They also worked once weekly with the clinician and then did 4 days a week at home. The homework that they did, see if I can get it to come up here, there we go, was training with an analog peak flow meter. And so this is a little device that you can blow into. I'll play the video again of the participant here in the top. You'll see she has the analog peak flow meter in her hand. Oops. Let's see if it'll play again for us. There we go. And so you place the device in your mouth and she can cough, and then she can actually see the value, the peak flow value of how strong that cough was. So we use that as a way to have some feedback about the experience. And again, they did 25 coughs per day, 5 sets of 5, just like the EMST group was doing, but with the EMST device. So in terms of the results, we assessed the eligibility of 75 participants, and I should tell you this is pretty hot off the presses, so it's not published yet, but we hope that it'll be published soon. 65 individuals were randomized, half to EMST, half to SM-TAP. COVID did cause the lab closure at some point, and so we did have to end the study prematurely, but we ended with about 30 participants with, with 30 participants with the EMST having full data sets and 28 in the SM-TAP group. Happy to report there were no adverse events throughout the study. You can see in terms of the characteristics that the groups were pretty well matched in terms of age, disease duration, and severity. So first, the study, if you remember, there was this delayed period where we kind of just wanted to see if you did 5 weeks of nothing, what would happen. And what we found is that over those 5 weeks, there was in fact a reduction in voluntary cough peak flow, though quite slight, but it was statistically significant when controlling for coughs. But there was no change in their maximum expiratory pressure over that time. But now to the good stuff. So what happened in terms of the treatment? So in terms of the treatment, both groups, the SM-TAP group and the EMST group, improved in terms of their peak expiratory flow rate for voluntary cough. The SM-TAP group had about a 0.45 liters per second increase, and the EMST group about 0.18. In terms of MEP, actually both groups also had an improvement in their maximum expiratory pressure, but in this case, the EMST group had the larger increase, 21%, versus SM-TAP, 9%. And I think these findings make a lot of sense, again, given the target, what we were targeting with each of those treatments, right? Expiratory pressure, expiratory muscle strength training, certainly more focused on increasing MEP, whereas the skill training was really focused on improving peak flow. And so we saw that kind of bear out in the results. In terms of the clinical transference, we looked at swallowing. We actually did not find improvements, statistical improvements in terms of penetration aspiration scores. And that was also the case in the more severe swallowers, but certainly our folks, the data was skewed towards kind of less impaired swallowing. So that's certainly something we need to explore a little bit more. And then we wondered about the clinical transference to cough sensory function. And what we found here is that for reflex cough peak flow, only the SMTAP group improved with higher peak flow for reflex cough after training. And we also found that only the SMTAP group had an improvement in their perception of coughs, or a change in their perception of cough stimuli after training. And so again, I think this makes sense because in this case, the expiratory muscle strength training wasn't so much focused at reflex cough, whereas in the SMTAP group, we really were targeting in many ways reflex cough function and the upregulation of the urge to cough. Interestingly, neither group really reported a change in swallow pulse scores. But we think that something good here is that they're not reporting a reduction in their quality of life. So we should hope that the approaches aren't too burdensome, and no change in voice, but the reality is that most of our participants were on normal diets. So we were really pleased to see that many of the airway protective outcomes, particularly related to cough, improved with both expiratory muscle strength training and SMTAP, and that there did seem to be really a role for skill training in a population like Parkinson's disease, again, that really has issues of motor organization. And so then a question that remained was, what happens when you put those two types of training together? Is there an additive benefit of doing both EMST with skill training? And then the pandemic had us ask a very specific question, which is, can you do this via telehealth? And so we did actually embark on that work and have some data to share in that regard as well. And so I'll just, give you the punchline, which is that you can also do this via telehealth, or we believe that it is feasible. So we did a feasibility study where we paired expiratory muscle strength training and cough skill training via telehealth. This study includes 20 participants, not all of which had Parkinson's disease. So of these 20, 12 had Parkinson's disease. We had a couple with Lewy body dementia, MSAC, and cerebellar ataxia. MMSE scores ranged from 23 to 30, so we didn't really exclude participants based on their cognitive function. We also didn't exclude based on up or download speed for telehealth. We had 8 participants that had care partners who were active during the sessions. And so just to kind of give you an overview of what we did. So one thing that you can imagine is that via telehealth, it's hard to do maximum expiratory pressures, right? Usually, if we're doing kind of maximum expiratory pressures appropriately, then you would be using a respiratory manometer to get the value. That's not something that we can send to folks' homes. That's not clinically feasible. But Aspire Products does have on their website a way that you can use the EMST device to try to get a proxy measure of maximum expiratory pressure. And so we went ahead and used that methodology to get our pre-treatment proxy of maximum expiratory pressure. Then participants completed 4 weeks of expiratory muscle strength training. In this case, instead of once weekly sessions, they were getting twice weekly teletherapy sessions and then 3 days of home practice per week. And then we had the post-treatment assessment, again, using the EMST device as a way to get the proxy for maximum expiratory pressures. Then the cough skill training, certainly there are some aspects also of SMTAP that I described before that we can't do via telehealth. So instead we used the device that was part of the home practice for SMTAP, that analog peak flow meter, and used that for cough skill training. We used that device to then get a baseline measure of cough peak expiratory flow rate, and then the post, we did the same. And folks completed just 2 weeks of cough skill training. So really the primary reason that we did the study was really to understand whether it would be feasible. We didn't know if doing the MEPS via telehealth, especially in folks with different kind of cognitive abilities and with different technological abilities, whether we would really be able to do it in a timely fashion. And we know that that's so important in terms of translating to the clinic, right? You don't have 1 hour to try to get people's MEPS via telehealth. And in our mind, kind of the cutoff for clinical feasibility was whether we could kind of get these measures and get through the treatment within a 30-minute window. And what we found is that it is in fact feasible to get objective measures of cough effectiveness. So this peak expiratory airflow measure from the analog peak flow meter and maximum proxy, I should emphasize that, of maximum expiratory pressure from the EMST device. Initially, it took just about 18 minutes, a little less than 18 minutes for folks to complete both the MEP and plus EMST training, and then just actually under 18 minutes too to do peak flow and cough skill training. So both of these actually from the get-go were under 30 minutes. And what we found is actually as time progressed and as treatment sessions continued, there was a significant decrease in that amount of time too. So in terms of its clinical translation, we think it's something that can be done in a timely manner via telehealth. And then in terms of a more kind of exploratory finding, we also wondered whether there might be improvements in MEP and peak flow with the training via telehealth. And we found that that was the case too. There was a significant improvement in cough peak expiratory flow rate in these patients with movement disorders and in that proxy measure of maximum expiratory pressure in these folks with movement disorders as well via telehealth. So we were quite pleased to find that. I think it's something that we need to explore further and understand more in a more diverse set of participants. Certainly there's some validity work that we need to do here, right? We need to compare kind of this approach of getting MEPS via telehealth to what that value looks like in person. But I think that this is promising work, and hopefully for those of you that are using telehealth, which we all are using telehealth a lot more than we used to be for sure, I think we can think about this in terms of the future repercussions for improving kind of a more hybrid approach to care, right? Something that perhaps includes both telehealth and in-person services to really maximize adherence, but also to maximize access to care. You know, our participants were really happy to have the opportunity to complete this treatment via telehealth. And even those that were skeptical to start, I think including us, were skeptical to start, really were quite pleased by the end and have a hope. And I think that this is been borne out in other studies too, some recent work through the National Parkinson Foundation, that folks in part with Parkinson's disease really are thinking that post-pandemic they want to continue with telehealth treatment. So I think that this is a direction that we need to continue to explore. And there's certainly more for us to understand about expiratory muscle strength training and Parkinson's disease as well, as it relates to longer periods of time and what those functional benefits are. And then also what is there potentially an additive effect of pairing the strength training with a more skill training approach. So with that said, I think I'm at my 30-minute mark, and I again thank you all for listening. And I need to thank the Michael J. Fox Foundation for the funding of the RCT. I thank my collaborator, Dr. Hagland at the University of Florida, collaborator and friend, dear friend, and the wonderful people in my lab that do most of the work, and then I show up here. So thank you.
Thanks so much, Michelle. That was a lot, and I myself have many questions. There's a lot coming in from the chat too. You have about 156 participants that just listened to that. Nice. So that's bigger audiences than when we get invited to go places. So definitely an impactful talk tonight. I'm gonna lead off with a question with regard to, I mean, that's the first I'm seeing that study with the utilization of the analog peak flow meter. A lot of people, you know, are talking about normative peak cough flows. How do they use that peak cough flow meter? Where can they get it? And where do we begin to define things clinically where we really should be raising our hand and saying, you know, that cough peak flow, when I measure it during my assessment, is abnormal. And you know, is this the time to implement either the EMST, the combined modality that you showed, sort of strength versus skill? What have you learned from the literature and clinically and working with the persons with Parkinson's disease on these values?
Yeah, I think that we all wish there was just one value that gave us all the answers. But I think that what is more important is looking at these functions holistically, right? So, I mean, I think we need to look at it from kind of three angles. One is screening. Certainly, I think that using cough peak flow to screen for aspiration risk is something important, and we often do this in our own clinical work where we've had individuals that otherwise aren't reporting kind of issues with their swallowing. They seem to be well, but their cough peak flow is strangely low. And then we go on and do an instrumental assessment of swallowing and go, oh, look at this, this person has, pretty significant airway invasion, for example. So it certainly has a role there. But if we're thinking about our comprehensive evaluations of airway protection, it has a very important role there too, right? Which is defining the effectiveness of their cough. And there's actually a recent study by one of my PhD students that found that voluntary cough effectiveness peak flow is predictive of a patient's ability to clear aspirate out of the airway. So if you have a patient that has aspiration, I think that you need to probably lower your standard for what you think is too low of a peak flow. If you have a patient that doesn't have aspiration risk, then maybe your, a slightly reduced peak flow is okay, right? But I think you need to look at the patient holistically. What are the functional deficits that they're having and going from there? But I think that too, we need to do a better job. I think part of the problem with the cough studies out there is that we've all used different methodologies, different peak flow devices, different experimental studies. So I don't think that we actually have a really clear cutoff quite yet, but I think that that's something that's on the horizon for sure. And Dr. Hegland's work, I think, is certainly headed in that direction.
Right. So, for the group, if you look at the literature, if you're producing 250 liters per minute or less, you've got a pretty severe deficit in your ability to drive out a hard cough. And Michelle, I'm thinking back to the work, remember, of Carol Smith Hammond, right? Early on, when she came out of Paul Davenport's lab and did that study with patients with stroke, she was one of the first ones to show that correlation between aspiration and voluntary cough. So it's great to hear that your students sort of picking up on that work, because that study was missed by speech pathologists because it was, put in a physiology journal. But I think, just as the speech pathologist listening, there's such a strong correlation between strength of cough and the relationship between penetration, aspiration, scale scores. So that's going to be great work coming out from your student. And I just have to, as a side note, I have to laugh because when Michelle said her students do the work and she just shows up, let me tell you, on that largest clinical trial at the time in Parkinson's disease, there's a reason my name's at the bottom, because I was the mentor. She did all the work and I just showed up. So full credit to Dr. Troche on all the work on that particular landmark study. So just food for thought. The interesting results that you showed, I had a question come in. They said, well, instead of doing the SM tap, why don't I just have my patient just do voluntary coughs over and over? Do I need to use the device per se, clinically?
The peak flow, I think that there is a study by Dr. James Curtis, who's a PhD student, was a PhD student of mine, now is a postdoc, in it's a single subject experimental design. He used voluntary cough skill training, so just the peak flow device, without the capsaicin, without the real-time biofeedback. And he found improvements in voluntary peak flow and reflex peak flow. So I think that's promising. That's certainly one person, but I think also then in the telehealth study, we saw that it seems that there's that improvement in peak flow. We don't know how that translates to functional outcomes. In Dr. Curtis's study, there was an improvement also in airway invasion. That participant was also receiving some other treatment approaches, but I think it's possible, but something that we have to study in a larger group. But I think in terms of, I think we can feel confident that their cough peak flow will improve. Transfer of that to, for example, response of cough or appropriate cough response to airway invasion. I think that is something that we yet need to understand.
Right. And to your point, I mean, to the question, you could certainly cough to cough better. But if you're having to objectify where they started and how you change that, either through a telehealth program or your clinical program, you need to have an objective measure to do that. And so
sure. Yeah.
Yes,
So if we're talking about just at all using a peak flow meter, I think the benefit there is, several. One is that, like you said, you want the ability as a clinician to track their function over time. Peak flow makes very good sense for that. It also, for participants, for patients, I think something that they love about the EMST device is that it's tangible. They take it home. They know if they're doing it correctly or not, right? Versus, I want you to do this thing hard. I want you to do this thing soft. I want you to do this thing this other way, and not knowing whether they're doing it that way or not. And so the peak flow meter also provides that, which is they know, okay, this is my target. I'm meeting it. I'm not meeting it. And so I think that it helps with their performance, but it also helps with adherence because it gives them, it's something motivating. So I think on several levels, and they're incredibly cheap. They are on Amazon for like $20. So
and you hit the nail right on the head. I mean, that's always been the benefit of any type of device-based training or anything. It doesn't, even if you're speaking outside the speech pathology literature, that people need to be able to see a goal, and watch a goal, whether they're listening to it, whether they're visualizing it. So there's a good literature about that on adherence. I did have a question for you. I noticed in your video that the patient was sequentially coughing. Mm-hmm. Could you explain the sequential cough and how that's measured with the device, and the single cough, and what should people be using?
Mm-hmm. Yeah, so this is something when Dr. Hegland and I first, we're kind of designing our studies, and what did we, what cough is important, voluntary, is it reflex? Then we were also kind of like, well, how about single versus sequential? Because when you think about, if we're always going back to the ultimate goal is to improve the effectiveness of a person's ability to clear the airway, really sequential cough is going to be the most effective in doing that if it can be coordinated and strong. And so we started to use as our cue cough as if something went down the wrong pipe, to have people execute a sequential cough. And so that's something that we've targeted over time. But when you use the peak flow meter, you're only getting the highest peak. So you're really only getting the peak value from that first cough, not the subsequent ones. But again, it's about, if we are truly working on coordination, then we need to be coordinating the actual type of cough that it is we want them to perform. And our ultimate goal would be a coordinated sequential cough.
Right. That's interesting. Have you studied at all whether the second or third or fourth epoch matters relative to airway clearance? Or,
we haven't, but it's an important question. Well, so something that we've thought about too is it worth, for example, trying, focusing so much on a sequential cough if it's always going to be disorganized? Or in that case, should you just switch to at least trying to get a really good single cough? So, I mean, I think those are the types of, experiences that clinicians have all the time, right? When, where am I going to get the best bang for my buck? And I think that's something that clinicians are good at realizing, okay, this is not, this isn't going the right way. Let's try something a little different. But I think that the ultimate goal should be that kind of coordinated sequential cough if we're really trying to especially kind of clear lower airways.
So the generalization of the literature, some people are working with, as you mentioned, stroke and ALS and MS. The common question, I know it's a hard one to answer, but just from your experience, you're working with a lot of clinicians and people in the field. When can you start this stuff? When is it, in your opinion, and do you feel that it's safe to be implementing a sequential cough treatment or, an EMST device? Do you have an opinion on that?
I do have an opinion only because having clinically worked with so many people with Parkinson's disease, something very early on in my clinical career, I felt like I was always surprised. Like I thought, oh, I'm sure like we're going to do an instrumental assessment. This person's going to be fine. And then it'd be like, oh, okay, well, not so fine. And then in our work with the movement disorders neurologists, we started to say, listen, send us folks the moment that they're diagnosed, send them to us. And it's not that we always find, major changes to their swallowing or cough function, but sometimes there are some subtle changes that are occurring. And we don't know. The answer is we haven't done research wise. We don't know if prophylactic EMST, for example, has an effect. But clinically speaking, in terms of what we know about exercise, deconditioning, what we know about the trajectory of these diseases, I mean, theoretically, it makes a lot of sense. And I can say from a clinical side, yes, I've done it many times where I've said, if someone's really motivated and they're like, I want to be doing something to potentially prevent or slow, the degeneration of my cough or swallowing, I have many times said, you should consider expiratory muscle strength training, and maybe not at the highest, with the most frequency, kind of at maybe 3 days a week or, some sort of modified approach. But I certainly think it has a place. But yeah, someone's got to do that work for sure and try to help us answer that question.
So, I'm just so intrigued, and I'm thinking back to a study that Karen Hagelin did on urge to cough. It may have preceded the study you're doing now, where they actually did show that EMST had an influence on urge to cough. I find the whole thing, regardless if EMST has an effect, but your work on the SM-TAP study, why is it happening, do you think? Because for the group to be able to influence a patient's urge to cough, to figure out, like, for them to sense that first penetrant in the airway, that's such an important change you're discovering. Why is it happening, do you think?
With EMST?
Oh, no, with your methodology. Yeah, with your
yeah. I mean, I think that with EMST, I think there's so much to learn by looking at so many different researchers have looked now at airway protection in different populations. And yeah, the findings are really different. Sometimes there's swallowing improvements, sometimes there's not. Sometimes voluntary cough improves, but reflex doesn't. Sometimes reflex improves, And so I think a lot of that is mechanistic, right? Like, what is the pathophysiology of the airway protective deficit in someone post-stroke versus, because I know that study for the increased urge to cough for Karen, that was in stroke.
That's right.
ALS versus PD versus MS, right? Those mechanisms are all so different. Certainly, I think it's telling us, I think Kate Hutchison's high resolution manometry paper is important because it is showing that kind of increased positive pressure in the upper airway, which who knows what it's, warming up in there or changing. Some of it too probably is, I don't know, want to call it placebo or behavioral or just an increased awareness of I should be paying attention to something in the airway. Maybe it's something about the education we're giving people, right? I think with SM-TAP, we specifically were targeting that. We wanted people to kind of pay attention to a stimulus in the airway and respond to it with hopes that would transfer. I think we would have been happier if we had seen the PAS scores change, but I think
Right.
there's more for us to understand there. But certainly their reflex cough function did change, as did their urge to cough ratings. So there's more work for us to do there, because I do think that if we want, that really is kind of like that interface that we really want to improve. Someone's ability to kind of sense not just that something really intense is in the airway, but that even more subtle amounts of something are in the airway, and then respond with a functional, productive cough.
Yeah. So last question, combined modality. I mean, I think you elucidated tonight, you know, it's not one, it's 1+1 or 1+1++1, right? And I guess, can you give a final comment to clinicians out there about, you know, sort of the trial and error that you've gone through, and, you know, kind of what made you think this way, you know, strength versus skill building. I mean, you have a large knowledge in sort of the neuroscience literature. I mean, why is your finding important?
Well, I think that, you know, the reality is, you know, there's always been this people always bring up expiratory muscle strength training is not swallowing specific, you know, especially kind of early on in that work. And that is 100% accurate. And, you know, I think that there is, you know, researcher Michelle, and then there's clinician Michelle. And, you know, most of the time I try to be both at the same time. And when, you know, though in those research studies, we had to look at EMST by itself, that's where we were in the progression of understanding that approach. I think we all knew that mechanistically, you know, a lot of these populations we're working with also have issues of coordination. So I can say that personally, clinically, I think that, you know, I can probably count on one hand the times that if someone had swallowing deficits, that I only gave them EMST. It did not pair that with something swallowing specific. Right. And so we were thinking the same with cough. I think that you could make an argument that some aspects of EMST do help with the coordination of cough, right? Because it's a little bit more similar in terms of tasks, deep breath in, you know, blowing out forcefully. But I think the reality is that we probably do need to think in most neurogenic populations where there is both reductions in peripheral strength and issues of motor control, that you're going to have to pair something strength training and something skill based. And for some people, it's going to be more important than others. So if you literally, you know, I feel like this is an example you used to use. If you want to improve free throws, but you can't get up from the chair to throw the ball, then it doesn't matter if I do skill. Right. You need to build that, you know, also kind of that foundational strength to then overlay the skill on that. And so, I mean, I think that now as the research base is increasing, then we can start to ask these more nuanced questions. What is best? This versus this plus this. And, you know, I think that that's how we really are going to come up with the most clinically translatable findings too for clinicians. So I'm hopeful that a lot more of that work is on the horizon.
You have such great work coming out of Columbia. You see all your doctoral students there. It does take a village. Michelle, believe it or not, this work in this space, which you were part of the very start of it, is now, you know, 20 years plus in, right? And it takes that long. It's hard to believe, you know, from bench to bedside. It's been, you know, 20 plus years with people studying expiratory muscle strength training. Thank you so much for your time, for sharing this information. Keep an eye on Dr. Michelle Troche's work. You'll often find her obviously presenting and inviting at swallow conferences, DRS, Fall Voice, etc. Keep an eye on all of her doctoral students. She's got her Twitter page, her Facebook page. Thank you so much, and we'll talk with you soon.
Thank you.
Thanks everybody for joining. Bye-bye.
Yeah, absolutely. Good night, everyone. Bye.
Bye-bye.